Hi everyone, I'm Joseph Leung, and I'm an adult endocrinologist with UBC and Vancouver General Hospital. Today's topic is Introduction to Insulin Pumps, and this is a crash course all about insulin pumps, an intro to it. If you've never learned anything about insulin pump, this is probably the video that you should watch. There's also the previous video on carb ratios, insulin sensitivity factors, and sliding scales. So if you haven't watched that yet, I'd probably recommend watching that first because this video builds on some of the materials from that one. So we're going to dive right in with this first case. This is a 21-year-old with type 1 diabetes who saw pediatric endocrinology for the last time 8 months ago. He has not seen adult endocrinology yet. They're on a Medtronic insulin pump and presents to ER with vomiting and confusion. The blood sugar is very high at 42, with a venous pH of 7.02 and a beta hydroxybutyrate that is high. He's being admitted to the internal medicine service. How should his insulin pump be addressed? Should we increase his basal rates? Should we change his carb ratios from 6 grams to 5 grams? Should the infusion set and tubing be changed? Should we give him an insulin bolus through the insulin pump stat, or should we remove the insulin pump? So think about that for a moment. You can pause this video and go through this case a little bit. We'll review the thought process in this particular case at the end of the video. So this is case 2. This is a 14-year-old who's at diabetes count for the first time, and they're on an Ipsomed insulin pump with the following pump settings. So you can see all the basal rates there, the carb ratios, and the ISF as well. This camper has had many low blood sugars throughout the camp experience so far. So which of the following options should be considered? A, drink juice before rock climbing and low ropes activities. B, drop all the basal rates. C, refrain from high intensity physical activity during camp. D, set a temp basal during our capture the pump activity. And E, switch insulin delivery to an MDI regimen. So once again, you can pause this video, give this a moment and think about what's going on in this case, and you can try to commit to an answer as we'll review this case at the end of the video as well. So the objectives of this talk is to showcase the different brands of insulin pumps and also some of the features of each of them. And in the second part of the talk, we're going to talk about the basic clinical management of diabetes using insulin pumps. Before I go any further, I would like to bring up this reference called Pumping Insulin. It is a book that a lot of this material is taken from. And so if you have a chance or you want to learn more or read more, you can search up this book and you can read through some of the more details that it gets into as well. So firstly, what are the different types of insulin pumps, especially which ones are available in British Columbia? So firstly, what is an insulin pump? Well, it is a device that delivers insulin continuously through a subcutaneous infusion. So that's just under the skin. So there's typically a plastic cannula that goes underneath the skin, and there is a mechanical device that is able to deliver that insulin into the body that way. Insulin pumps are also known as continuous subcutaneous insulin infusions, or CSII. So you might see in the research literature this term being used. So if you ever read about CSII, that's what that means. It just means insulin pump. Insulin pump usage has increased dramatically in the last few decades. So just based on US data, even up until 2020, you can see the use of insulin pumps has risen exponentially. And in Canada, it is the same thing. There are many, many benefits of an insulin pump. I'm not going to go through all the evidence in this talk. That's not the purpose of this talk. But as you can see, there are many benefits, including better diabetes control. You can set temporary basals. You can deal with a dawn phenomenon, which is very, very difficult to deal with insulin injections. But with an insulin pump, these are things that we can more precisely manage, and we can just really pinpoint the basal rates or the carb ratios at different times of day to manage those higher blood sugars or even low blood sugars. So if I were to divide insulin pumps into two main groups, I would say there are those that are tubed and those are tubeless. There are probably other ways to divide up insulin pumps as well, but this might be one of the ways of separating them. And in fact, all of these insulin pumps here are the older versions. This one up here is one of the old tubed pumps, the Animus pump, which is actually no longer available as of 2018. This one on the upper right here, this is one of the older Medtronic pumps, which is also no longer being sold by the company as far as I am aware. And then here in the bottom, there is the Omnipod, which is a tubeless pump. This particular one is the older Eros model, but there's also the newer Dash model, and also Omnipod 5, which we'll mention later on in the talk as well. But these are kind of the two ways um, that insulin pumps can be separated. As you can see here, there is typically a mechanical controller that is pumping that insulin. And in this particular Medtronic, so this is a tube pump, this particular brand, this insulin is pumped through the tubing into the infusion set and then under the skin through this kind of plastic cannula into the body. This is the Omnipod, so this is the tubeless pump. And this is the pump here, and it's controlled by a separate controller, which you'll see in a different slide as well. And then when you remove the pod, you can see that this is the plastic cannula, and that's what is inserted under the skin, and that's where the insulin goes through and into the body. So in British Columbia, there are 4 brands of insulin pumps that are available. There's the Ypsomed, the Omnipod, Medtronic, and then also the Tandem. Ypsomed, Omnipod, and the Medtronic pumps are all available through what we call Tier 1. So that's no questions asked as long as the individual has diabetes. Both type 1 and type 2 diabetes will be covered. Both adults and children will be covered as well. Medtronic used to be Tier 2, which means that there were some special circumstances, only under special circumstances could you access that. But as of this past year, Medtronic is now Tier 1. And then the Tandem pump is not covered by BC Pharmacare. But if if an individual has extended health coverage, private health coverage, that's one way that they can access this pump. This is the special authority form to fill out in order to apply for an insulin pump. It does not need to be from an endocrinologist. A generalist, an internist, a pediatrician can also apply. Of course, now many people in the province are using the e-forms, electronic version of this form. That's a bit easier, but as you can see, there are some things that you check off. That the patient does not have an active warranty. If they do already have an active warranty for an insulin pump, they have to fill out this current insulin pump user section. They have to agree to age-appropriate comprehensive care and diabetes education, so on and so forth. And in the past, there was a section where there is a rationale for Medtronic device, but this is no longer needed since Medtronic is a Tier 1 pump now. So first off, we're going to talk about the Ypsomed pump. So as you can see, it's a tube pump. It can connect to the Dexcom G6 as well in some of the later versions of this pump. It has an easy to use pump interface, very sleek, kind of small design with a lot of different icons. There's minimal words on the pump, so it's kind of it tries to be very kind of self-intuitive that way. The reservoir holds 160 units of insulin, and the infusion set needs to be changed every 2 to 3 days. There's a special feature called the blind bolus function where um, you can preset. If you click it once, it delivers, one unit of insulin. You press it twice, it's 2 units. And so you could be in a meeting and needing to bolus insulin. You're bolusing without people even know that you're administering insulin to yourself. And then some of the carb calculations and things happen through the Ipsomed app on the phone. And there is this automated insulin delivery option through some of the later versions of this pump, as I was mentioning, but many people using this pump are using it through a manual mode. So this is the Ipsomed, and then the next one is the Omnipod, which is also tier 1. This is the older Omnipod Eros pump, and then the newer one is the Dash. And as of last month, the Omnipod 5 became available in Canada. It was approved by Health Canada last fall, and now it is starting to be available through the company. So this is the only tubeless pump that is available at this time. The Eros model, it communicated through radio frequency between the PDM, the personal diabetes manager, and the pod, whereas this newer Dash model communicates through Bluetooth from the PDM to the pod. So these pods are not interchangeable between the different models. Each pod holds 200 units of insulin, and each pod lasts for a maximum of 72 hours, plus a little bit of grace period a few hours after that. So there's the Omnipod 5, which is now available, and that offers the automated insulin delivery with Dexcom as well. This is, I think, some older version of my slides here mentioning the Horizon, but yeah, it's now called the Omnipod 5. And so this is available in BC. And then we have the Medtronic as well. This is a tube pump, and there can be Bluetooth connectivity with the phone as well, so that some of the sensor data, some of the pump information can go into the phone. The minimum basal increment here is 0.025 units per hour. Whereas for Omnipod it's 0.05. So it's a bit more precise in that way than Medtronic. Each reservoir holds 300 units of insulin, and the infusion sets are to be changed every 2 to 3 days as well. And there is now connectivity with the new Guardian 4 sensors, which don't require any calibration, just one calibration to get into the auto mode, the automated insulin delivery, and then they're good to go. We're not going to talk about automated insulin delivery in this talk per se, but we will go into some of the other manual mode settings in this talk. And as I mentioned, Medtronic is now covered tier 1 in BC. The tandem t:slim pump is not available through pharmacare, although pharmacare will cover the pump supplies, but not the whole system, the pump itself. So it is a tubed pump, and there is Bluetooth connectivity to the phone as well. A few months ago, there was a software upgrade where Dexcom G7 is now compatible with the tandem t:slim. It's a colored touchscreen, and it holds 300 units of insulin as well, just like for Medtronic. And most commonly, people are using the Control IQ system, which is the hybrid closed loop or automated insulin delivery form of this pump. And yes, once again, not covered by pharmacare. So here is a chart summarizing all of these different insulin pumps. This is the chart that I wish I had at the beginning of fellowship, but here I've made it for you to summarize some of the special features of each of these insulin pumps for your quick reference. So now that we've gone through the different insulin pumps, we're going to talk about how you might manage the insulin pump. So managing an insulin pump is very similar to managing multiple daily injections of insulin, MDI. So just like in the previous talk, we mentioned about how we need to use insulin for three major reasons. There's the basal requirement, there is insulin for food intake, and then there's insulin for correction. Likewise, for an insulin pump, there's what I call the big three settings. That's the basal rates, the carb ratios, and the ISFs. The management of this corresponds, and many insulin pumps have this what we call the bolus calculator or bolus wizard. It takes into account the glucose values, the carbs that you enter in, the grams of carbs that a person is going to intake, and then it'll recommend an insulin dose for patients. So in this way, it does these calculations automatically, and it can oftentimes make the management of diabetes that much easier. So we're going to take the example of Leo. He's 19 years old and on MDI and just transitioned from pediatric care. He's on glargine of 30 units at night and Lispro 10 units with each meal. The A1C is 7.4%. And we've now obtained pharmacare coverage for the Omnipod system, and he's just been shipped all the pump supplies. So how should we program his pump? Well, on MDI, the doses of insulin were glargine 30 units, Lispro 10, 10, 10. But how about on insulin pump? How do we program the basal rates? Well, what we're going to do is we're going to take that glargine of 30 units, and this is, 30 units once a day. But anytime you're changing from one regimen of insulin dosing to another regimen, it's a good idea to just be a bit more conservative. And so we're going to just take 80% of that dose. So 30 units times 80%, that's 24 units. Very convenient because 24 units in the whole day divided by 24 hours, that's equivalent to 1 unit an hour. So our initial settings for Leo would be to program in 1 unit an hour for the entire 24-hour period from midnight to midnight. Now, how about the carb ratios? What are we going to do for that? You'll recall from our last talk that that total daily dose of insulin value is very, very important. And certainly in this case, we can do that same calculation. So this individual is using 60 units total of insulin for the whole day. So we're going to plug that into our equation here. So 500 divided by 60 is 8.3. We're going to round up a little bit just to be a little bit more conservative. Once again, as the carb ratio is higher, it means they're going to get less insulin. So we're going to round the carb ratio to 9. And then for the ISF, we're going to do the same thing. So 100 divided by 60 is about 1.7 or so, and we're going to round that up to 2. So the ISF is 1 to 2 for the whole day. So these are the initial pump settings that we're going to plug in. Basal rates, midnight to midnight, 1 unit an hour. Carb ratios, midnight to midnight, 9 grams. And ISF, midnight to midnight, 1 to 2. So when he goes biking, he notices that his blood sugars go low during exercise and for 4 hours afterward. So one of the things that you can recommend in this situation is to use what we call a temp basal or temporary basal during exercise. So he was instructed to set the temp basal of minus 20% or 80% in some pumps. So that's basically the same thing for 4 hours. Temporary basals can reduce the amount of basal insulin given for a specified time duration. They can also increase the amount of basal. For example, if an individual is sick, and oftentimes for sick day dosing, they might require 20 or 30% more insulin. So that might be one of the ways that you want to account for it. Another option is during menstrual cycles, sometimes those blood sugars might be a little bit higher. And so that might be one reason why you might increase the basal, perhaps using a temp basal or else using a different basal program altogether. So now, 1 week later, so we programmed all of these settings. They're using the insulin pump for a week. And for whatever reason, they're not on CGM. We're going to get to CGM in the next talk. But they're documenting all these blood sugars through a logbook. This is somewhat realistic in the sense that sometimes there are missing blood sugar numbers in the logbook. But what do we notice? You can pause this video and take a look at these blood sugar readings. What are some of the patterns that you see? So one of the patterns that you might notice is that there's some higher blood sugar readings at breakfast. So these are fasting blood sugars, and these are higher. They're over 10. Our target is typically in that 4 to 10, 5 to 10 range. And so what should we do with these higher fasting blood sugars? And as you might recall from the last talk, presumably this individual is not eating overnight. And so if the blood sugars are truly climbing overnight, that might indicate that the amount of basal insulin that they're getting is not enough. So one of the things that is quite common is what we call the dawn phenomenon. And the dawn phenomenon is basically with the cortisol peak in those couple hours prior to an individual awakening, that cortisol actually causes some higher blood sugars. And so they don't have any overnight lows, which is also something that's important to keep in mind because if they're having overnight lows, it could be that that morning high is due to the rebound effect called the Somoji effect. But the dawn phenomenon is much more common. Actually, even the Somoji effect is a little bit debated and controversial. But dawn phenomenon, I think, is well known and quite common. So in this kind of a situation where, as you can see, there's lots of higher blood sugars fasting, that's where you might actually increase the basal rate a few hours before he wakes up, and you might leave it at a higher rate for a few hours before turning it back down. So in this kind of a situation, you might bump up the basal rate by about 20% or so. So starting at about 5 a.m., we're going to go to 1.2. So from midnight to 5 a.m., it's still 1.00. But at 5 a.m. until 10 a.m., it's 1.20 units per hour. And then 10 a.m. all the way back until midnight, we're going to go back to 1 unit an hour. And in this case, we haven't made any changes to the carb ratios or the ISF. So now, in the second week, we take a look at the logbook and we see perhaps some other patterns emerging. So once again, you can pause this video and see what patterns you see now. So one of the things that you might observe here is that there are now some low blood sugars. In fact, there are some that are quite concerning, down to 2.8, 2.3, even 1.8. And one of the things that you notice is that all of these low blood sugars follow a high blood sugar. So what might be happening in this kind of situation is that when they have a high blood sugar, they're correcting for it, but then that correction is too strong. And you might recall that that correction is governed by that ISF, also known as the sensitivity factor, insulin sensitivity factor, or correction factor. So when it's too strong, then they could have a low blood sugar. So what we might want to do in this situation is we might want to actually make that ISF a little bit weaker. That means increasing that number. Remember that ISF is a denominator. So in this situation, their ISF to begin with was 1 to 2. Let's just give, for example, their glucose value was 20 millimoles. We're targeting 8. So when you go through that calculation, they're going to get a Lispro dose of 6 units through the insulin pump. But if we change that ISF to 3 with a blood sugar of 20 targeting 8, their Lispro dose is going to be a little bit less. So it's going to be actually just 4 units here. So this is one of the things that we might recommend is we're going to now change that ISF to 1 to 3 for the whole day. And the reason why we did it for the whole day is because if we go back and look at the blood sugar readings here, these lows that happen after every high, they actually happen throughout the day here. So that's why we're changing the ISF for the whole day. And then a few weeks later, we're taking a look at the blood sugar readings once again. And here we are also perhaps noticing another pattern. So you can also pause the video here and see what you observe. So one of the things that you might notice in this logbook is that there are a lot of higher blood sugars at lunch. The blood sugars at the different times of day, other than that, they seem to be mostly in target, maybe occasionally a little bit higher or some lows here, but those seem maybe a little bit random, not a lot of pattern to it, but there seems to be this recurring pattern of lots of higher blood sugars at lunch or before lunch. So what change should we make now? Well, in this kind of setting, perhaps what's going on is that the carb ratio at breakfast is not strong enough. So lots of highs before lunch. So in this situation, we're going to try to make that carb ratio stronger at breakfast only, which means that number is going to be lower. So initially we had set the carb ratio at 1 to 9. Let's say they got 50 grams of carbs. So 50 divided by 9, they're going to get 5.55 units through the insulin pump. However, if we change that to 7.5, the carb ratio to 7.5 grams, 50 divided by 7.5, that's 6.65. So they're actually going to get at least one additional unit during breakfast. So this is how you might make that change on the insulin pump. So from midnight to 7 a.m., we're going to leave it at 9 grams. But from 7 a.m. to 11 a.m., we are going to now change that carb ratio to 7.5 grams. And then starting at 11 a.m., going all the way until midnight, we're going to go back to the 9 grams. So there are a couple other pump settings that you might encounter as well. So together with the carb ratios, the ISF, and the basals, this is what I call the big five insulin pump settings. Targets, that's pretty self-explanatory. You're setting a blood sugar target for the pump to use in its calculations. So, whether it is setting it at the targeting a blood sugar of 6 millimoles, and then, correcting above 8 millimoles, that's something that you can set, and you can set different time frames. So overnight, there's a different target from what it is in the daytime, for example. And then there's this setting, the active insulin time, or the duration of insulin action. Some pumps you will see that wording used instead. So I'm going to attempt to explain that in the next couple slides as well. But you're going to see here that we've entered in these different targets for this patient in and the active insulin time. And the active insulin time is really based on the pharmacokinetics of the insulin that we put into the pump, and that is a rapid acting insulin. And I guess I'll take this opportunity to say that in the insulin pump, we're putting in that rapid acting insulin. The patient does not require any basal insulin anymore because we're basically using a continuous infusion of rapid acting insulin to mimic a basal insulin, basically. So the concept of active insulin time is very closely linked to insulin on board, or IOB. And so in this diagram, what I want to show is how these are linked and what active insulin time means. In a rather simplistic manner, it's probably a little bit more complicated than this. But let's say an individual has a blood sugar of 16 millimoles at 8 a.m. So that's a high blood sugar. And they're going to get some correction insulin for that. So let's say 4 units of Lispro. By 11:30 a.m., this individual's blood sugar has come down to, let's say, around 12 millimoles. So that's great. That's what we expect. We gave some correction insulin. The blood sugar came down. That's great. But the blood sugar is still above target here. Now, here's the thing. If the active insulin time is set at 3 hours, then the pump will interpret that by 11:30, so 11:30, that's beyond that 3 hours. The pump will say, oh, there's no more insulin on board because that insulin was only set for 3 hours. It's only active for 3 hours. So by 11 a.m., all that insulin that we gave at 8 a.m. is totally gone. So there, by 11:30 a.m., there is no IOB, so no insulin on board. And if you punch in 12 millimoles into the insulin pump, it will say you need to give additional bolus of insulin. And and it'll recommend something. However, if that active insulin time is 4 hours, then by 11:30 a.m., the pump will interpret that not all of that insulin given at 8 a.m. is used up yet. And there may still be some insulin on board. So they may not need to give more insulin, even though the blood sugar is above target. Or they might do a calculation and what we call reverse correction, and they might actually recommend an insulin dose that is less than what you expected if the blood sugar was just 12 millimoles. It will take into account the fact that there was still some insulin at 8 a.m. that is still active in this point, and it will reduce that amount. And every pump has a different kind of algorithm. Some of the pumps may incorporate some level of a decay function as to how much insulin is left at that time. But nevertheless, that's what active insulin time and IOB mean. And you'll see that on patients' pumps. One other concept I want to bring up is the menu map. So in this particular example, this is the Medtronic pump. You can search for these menu maps online. There are paper copies of them that you can perhaps ask the insulin pump companies or the reps for as well. And sometimes you might be going through an insulin pump setting change with a patient, but you're not sure how to get to it. This helps you to find the particular setting that you're looking for. So basal pattern setup is the place where you would change the basal rates. And then it's the bolus wizard setup. That's the place where you might change the carb ratios and the ISF, for example. There are some other kinds of settings here that, as you can see, can help you. One of the ones that I think is really helpful is the history section, and that's where you might look for the total daily dose of insulin that, as I said previously, was all important and can oftentimes help you double check if that carb ratio or ISF might be correct or in the right ballpark. But yes, bolus wizard setup, basal pattern setup, those are things you're looking for. There's some other concepts that are related to insulin pumps that you might hear about, square boluses or dual wave bolus looping. This is beyond the scope of our discussion for now, but you can feel free to certainly ask a pump trainer about it when you have a chance, and we can certainly go into those topics in a little bit more detail. And then for some of the pumps, you can also download a simulator on your phone to try it out. So for example, the Omnipod 5, the Tandem T-Slim, they have simulators on the phone, and you can go to the App Store, for example, and if you want to kind of try things out. If you are watching this video in preparation for diabetes camp, there may be opportunities at diabetes camp to try a pump, or if you're a resident watching this video, perhaps when you're on service with us, there may be opportunities for you to try an insulin pump with some saline in it, so you can test out some of the features and learn about how an insulin pump works as well. So in the last talk, I talked about how the MDI way of dosing insulin, it can very nicely hug that curve of physiologic insulin secretion. And likewise, an insulin pump can do that same thing by precisely programming in the different basal rates, the different ways of bolusing insulin, for example. And oftentimes, there can be a lot of optimization of one's diabetes management through the use of an insulin pump. I'm going to give you another kind of example here. So this patient has now been using their pump quite successfully for the last several months. And now he is a counselor at diabetes camp for one summer. So one night, an 8-year-old boy in his cabin wakes up feeling unwell. He's on a Medtronic insulin pump, and his blood sugar is 19.8. His urine ketones are mildly positive. Which of the following is or are the next best options at this time? So you can pause this video and think about this, but you can call the Medtronic customer care line, drink some water, take some long-acting insulin, go back to bed, remove and replace the infusion set, take some short-acting insulin by injection and check his blood sugars in 1 hour, or visit the nearest emergency department. You can think about that for a little bit. So in terms of what you could do, I would say C and D probably the most optimal things to do, because oftentimes what could be happening in this situation is that there is an issue with the infusion set. And so it's oftentimes helpful to remove that and put a new set in, but just to make sure that this kid is getting that insulin, we're going to give them Lispro through injection so that we know for sure they're getting that insulin rather than giving it through the new infusion set. And of course, we want to double check his blood sugars in an hour, make sure that it has come down, and that the infusion set is working. You might take a look at it, make sure it's not leaking. As for the other answers, I mean, you can always call the customer care line. They're very helpful. They're available 24/7. If there's a pump failure, these pump companies can get insulin pumps to an individual, even in a very remote location, within 24 hours. At Diabetes Camp, we are, quite a ways away from Vancouver. Even on a Friday evening, we can call a customer care line. By Saturday morning, there is a delivery person delivering a new pump to one of the campers because of this insulin pump setting. So it's not a wrong thing to do, but I think in the middle of the night like that, um, uh, you know, that might not be the best option. They might give you some advice that might include CRD as well, for example. For option B, drinking water is definitely a great idea when the blood sugars are high like that. But taking long-acting insulin might kind of screw things up a little bit because once you get them back onto their insulin pump, you might need to set a temp basal to 0% because you need to take into account that they now have this basal insulin on board through the injection for 24 hours. So this might not be the best option. Visiting the nearest emergency department, I know it's a possibility. Um, but at Diabetes Camp, we have a whole team of doctors, nurses, and other medical staff, and oftentimes we can treat mild DKA in this way. The ketones are mildly positive, the blood sugars are not that high. Mild DKA can actually be treated using an insulin pump, and you don't necessarily need to go to an emergency department for that. Of course, if you're not sure what to do or you need support or the individual is not doing well, then of course going to the emergency department is the right thing to do. In florid DKA though, taking off the insulin pump and managing through IV insulin is going to be the right thing to do in that kind of a very severe situation. So what might have been happening in that case? Why the kid's blood sugars goes to 19 in the middle of the night? Well, here's an example of a kinked cannula in the infusion set. So this would block the delivery of insulin and would could result in those higher blood sugars and higher ketone levels. This is a scan from that pumping insulin book, and I really like it because it shows some of the places in insulin pump where you can have some kind of malfunctioning, whether it is a pump failure or there could be a crack in the hub, there could be punctures, pet bites inside the tube. You can have failures of the infusion set, including leakage or kinking of that cannula. So these are all kind of troubleshooting of a pump. And as you become more familiar with insulin pumps, these are things that you can help to investigate with these insulin pump users as well to kind of figure out what's going on. Now, if you're seeing a patient on an insulin pump on the wards, so these are some of the things that you want to ask about in an insulin pump consult. So, of course, the big three, basal rates, carb ratios, and ISF. The big five, which includes a target and active insulin time. I think that would be really helpful as well. But also, what model of pump is it? What kind of rapid acting insulin are they using? How long have they been on the pump? What are the previous pumps they've been on? Their total daily dose of insulin through that history function that I mentioned. So these are some of the things that you might want to ask about. If time permits or in an outpatient setting, you might also want to ask about how often the sites are changed, which sites they use, how the pump is paid for, when the pump is due for an upgrade. So these are all things that you might consider. So we're going to go back to the cases that we mentioned in the beginning of the talk. So this is an individual who is in DKA. Their pH is 7.02. So this is a pretty severe situation here. They're presenting to emergency with vomiting, confusion, blood sugar is really high. So as I mentioned, the best thing to do in this kind of a florid DKA situation is to remove the insulin pump and manage this through a full DKA protocol with IV fluids, IV insulin, so on and so forth. In this second case, this camper is having lots of lows during camp. And this is quite a typical setting, especially when they have not been very active when they're at home. But then once they get to camp, they're doing rock climbing, they're going hiking and paddle boarding and kayaking, doing all these different activities. And as their body becomes so much more sensitive to insulin because of that, they can have lots of low blood sugars. I don't know that I would necessarily drink juice before every rock climbing session or every activity in order to manage those lows, but rather I think what I would do is drop all the basal rates. And then setting a temp basal during intense activity like capture the pump, which is basically capture the flag, but we have these pumps that the campers are trying to capture. Refraining from high intensity physical activity, well, part of the reason for camp is a safe and monitored setting where there are medical staff around and where these campers can do the typical activities at camp, have fun, enjoy themselves, interact with other campers. And so I don't know that that would be the best option. And then switching insulin delivery to an MDI regimen, that's always a possibility. But having lows like this, oftentimes that's not necessarily a reason to switch to an MDI regimen. We can certainly manage lows very easily by just reducing the basal rates and setting temp basals on an insulin pump. So I hope you've learned something from today's video, showcasing the different types of insulin pump brands and also talking about the clinical management of insulin pumps. See you in the next video.